Lung cancer, it's one of the most complex cases in all of medicine. And to really understand it, you kind of have to think like a detective. You're following clues, you're identifying the culprits, and then you're mapping out a strategy to fight back. And in this explainer, that is exactly what we're going to do. Let's start the investigation.
Every good investigation needs a roadmap, right? So here's ours. We'll start by figuring out the primary suspect, and then we'll ID the specific intruder. After that, we'll sift through all the evidence, the warning signs, and importantly, the false flags. We'll use our diagnostic toolkit to map out the full extent of the invasion, and then finally, we plan our counterattack. So let's get started.
All right, first things first, the prime suspect. In any investigation, you always start with the most likely culprit. So, in this case, where does the evidence point?
Well, when you look at the evidence, it is just overwhelming. Take a look at this number, 85 to 90%. That's how many lung cancer cases are directly linked to our number one suspect, smoking. And that's not just active smoking. We're talking secondhand smoke too. It is, by a huge margin, the most important clue in this entire case.
But a primary suspect rarely acts alone, right? There are always accomplices. And here we have to look at things like exposure to nasty stuff like asbestos and radon gas, general air pollution, and even a person's own genetic makeup. Age is also a factor we got to consider, since lung cancer is way less common in people under 40.
Okay, so knowing the risk factors, that's just step one. To build a really strong case, it's not enough to know what causes the crime. We need to identify the specific intruder. Because, as you're about to see, there isn't just one type of lung cancer.
Lung cancer basically breaks down into two main profiles. First, you've got non-small cell lung cancer, or NSCLC for short. This one's the most common by far. We're talking about 85 to 90% of all cases. Then you have small cell lung cancer, or SCLC. It's less common, but it has a reputation for being way more aggressive. It grows fast and spreads early. So two very different intruders, and that means they require two very different approaches.
So let's zoom in a bit on that bigger group, NSCLC. It's not just one thing. It's more like a family of related subtypes. The most common one is adenocarcinoma, which makes up almost half of all cases. Then you have squamous cell and large cell carcinomas. And trust me, knowing these different types is absolutely vital because each one leaves its own unique signature.
Think of it like this. Each of these subtypes has its own unique case file. For example, adenocarcinoma? It's often found in the outer parts of the lung, and, get this, it's actually the most common type we see in non-smokers. Squamous cell, on the other hand, is super strongly linked to smoking and usually hangs out in the central airways. All these little details are critical clues for understanding what's going on.
So now that we know who we're looking for, it's time to examine the evidence left at the scene. This means we have to sift through all the warning signs, the symptoms, but we also have to be really careful about potential decoys, or what we call false flags.
The body starts leaving a trail of clues for us to follow. You've got your local signs, things coming directly from the chest itself, like a cough that just won't go away, which is the most common clue of all. Then there are systemic signs that affect the whole body, like losing weight without trying. And then, really importantly, there are metastatic signs. These are clues that the cancer has spread, like headaches if it's in the brain, or bone pain.
Okay, and this is where the investigation can get really tricky. Sometimes the tumor itself releases substances that create false flags, symptoms that seem totally unrelated to the lungs. We call these paraneoplastic syndromes. So for example, a lung tumor might produce a hormone that causes muscle weakness, sending investigators down a completely wrong path. It's the cancer creating a very clever diversion.
With all these clues and potential decoys floating around, we need to call in the forensics team. It's time to bring out the high-tech equipment to get a positive ID. This is our diagnostic toolkit, the tools we use to confirm the intruder's presence beyond a shadow of a doubt.
The whole process is pretty methodical, really. It comes down to two main steps. First, we use imaging to get a picture of the crime scene. Then, once we have a visual on our suspect, we move to step 2, the biopsy. That just means taking a tiny piece of tissue to analyze in the lab. You have to see it, and then you have to prove it.
So usually the first look comes from a chest x-ray. It's like a quick snapshot of the scene. The thing is, it can sometimes miss things, and that's why the CT scan is so essential. Think of the CT scan as the detailed, high-resolution map of the area. It shows us the tumor's size, its exact location, and whether it's gotten into any nearby lymph nodes.
But what if we need a wider search? For that, we bring in even more advanced tools,
A PET CT scan is like a full-body-wide scan. It lights up like a Christmas tree anywhere the cancer might have spread. And if there's even a tiny suspicion it might have gone to the brain, a specialist tool, the MRI, is brought in to get a super detailed picture. Each tool has a very specific job to help us build the complete case file.
So, we've confirmed the intruder's identity. Now comes the next critical step. We have to figure out how far it's advanced. In medical terms, this is called staging. But for our investigation, let's call it what it is: mapping the invasion.
For non-small cell lung cancer, we use a system that's basically a GPS for the cancer. It's called the TNM system. T stands for the size of the primary tumor. N tells us if there's any lymph node involvement nearby, and M lets us know if there's metastasis, which just means it has spread to distant parts of the body. You put T, N, and M together, and you get a precise stage, from I all the way to IV.
Now, for small cell lung cancer, the map is way simpler. And that's because this type is so aggressive, it's divided into just two stages. Limited, which means it's stuck on one side of the chest, and extensive, which means it's already spread beyond that. It's a simple map for a very, very fast-moving target.
Okay, our suspect is identified. The invasion has been fully mapped. Now, it's time to plan the counterattack. This is the moment where all the intelligence we've gathered gets used to build a precise, strategic battle plan.
And look, the battle plan has to fit the enemy you're fighting. For NSCLC, the strategy is all about the stage. Early stage cancer, you might be able to remove it with surgery. More advanced stages, that's going to require a combination of different therapies. But for SCLC, because it's usually already widespread when we find it, chemotherapy becomes the primary weapon. It's designed to fight on all fronts at once.
When you look at the arsenal for NSCLC, it's incredibly diverse. You've got the traditional weapons, of course, like surgery, radiotherapy, and chemo, but the real game changers have been the newer tools. Targeted therapy works like a smart bomb, only attacking cells that have specific genetic mutations. And immunotherapy? Wow, it's revolutionary. It doesn't even attack the cancer directly. It just unleashes your own immune system to go do the job.
For SCLC, though, the strategy is much more focused. Chemotherapy is still the cornerstone, the mainstay of treatment. Why? Because this intruder is a systemic problem almost right from the start, so you need a systemic weapon to chase it down, no matter where it is in the body. Radiotherapy is often used to help out, but it's chemo that leads the charge.
So our investigation has taken us all the way from the first suspects to a full-on counterattack. But a case like this is never really closed. As our treatments keep evolving from these blunt instruments into highly precise, personalized weapons, we're left with this really hopeful question. What will the next generation of counterattacks look like? That right there is the new frontier in this ongoing fight.